We're going to now talk about headaches and what are the signs that we look for our clue towards a diagnosis. So this is a 22-year-old female. She presented to an ophthalmology clinic. She had a little whiplash injury while she was driving a car. It was fairly severe. She lost her glasses at that time, and she then started complaining headache after the injury. Her visual acuity was normal, but she said maybe her headache is related to because she lost her glasses. So on second day, she presented to an ophthalmology clinic for examination. And I would like to acknowledge Dr. Devendra because he gave me this photograph. So what do you see here? Patient who had an injury and lost her glasses complains of headache and neck pain. So what do you see in the top picture? There is a mild left side ptosis. That's a very mild ptosis. Now patient is complaining of headache, acute onset, hyperacute onset of ptosis. The other thing that you need to look at is the pupil. Would anybody would like to say what's going on in the pupil? Anisocoria, yeah? Anisocoria? In dim light. So what do you think is happening here? Anisocoria in dim light. Very good. Horner's syndrome. So just for explanation to other people. So if you see this patient had difference in the size of the pupil. The left pupil was smaller than the right pupil. It's not very clear in the top photograph, but the left pupil was smaller than the right pupil. So if you have this kind of patient, the next thing that you do is to see what happens to the difference in size of the pupil when you examine the patient in a bright light versus in a dim light. So if the difference in the size of the pupil increases when the room lights are off in a dim light, you know that you are dealing with sympathetic system problem, because sympathetic system normally is supposed to dilate the pupil. In a dim light, one pupil, the affected pupil, did not dilate, the normal pupil dilated, and that's why the anisocoria increased. Conversely, if the anisocoria increased in a bright light pupils are supposed to constrict. So abnormal pupil did not constrict, which is a parasympathetic problem, so that you know that you're dealing with a parasympathetic system problem. So yeah, patient with a mild ptosis with smaller pupil on the same side, you're dealing with left Horner syndrome. What next? Patient had a whiplash injury while she was driving and is now also complaining of headache and neck pain. What should we do next? MRI, and as Dr. Maskari said, what are we suspecting? Of course, MRI is something which we'll do because you mean pre-ganglionic or post-ganglionic? Well, okay. Generally, I mean, the postgraduates in the session, if there are any, excellent. Dr. Raju said that. This is a medical emergency. Patient who is complaining of pain, headache, and has Horner syndrome, it's a medical emergency. Why is that a medical emergency? Is because first and foremost, you want to rule out dissection of larger vessels, dissection of carotid artery system, and they present with acute facial or neck pain. Now there are some startling numbers here. The ischemic strokes, 2% of all first-time ischemic strokes are caused by this dissection of larger vessels, and 20% of all strokes below the age of 30 are because of dissection of larger vessels. The most important is 50% of these patients first go to ophthalmologist, and that's the reason why we should be aware. Anybody who has an acquired mild ptosis, look at the pupil very carefully. If you have even slightest doubt that there is an anisocoria, the pupil on the affected side is smaller, look at what is happening to that pupil, switch off the room light and switch it on. Have a very dim source of light, because our irides are brown, have a very dim source of light to look at the size of the pupil to see how it is changing. Because 50% of these patients, a potentially fatal condition presents to us first. And if the ICAD can have 60% permanent neuronal damage on discharge and 5% mortality rate. So Horner syndrome, will continue the discussion on Horner syndrome. That was about the pain. If patient has Horner syndrome and complains of pain in shoulder, scapula, arm or hand, you are looking at a Pancoast tumor, a tumor of the apex of the lung. Again, 20 to 50% of the patients of Pancoast tumor would have Horner syndrome on presentation. So in other words, a lot of these patients probably would go through us, maybe right in the beginning. And the third uh, scenario of Horner syndrome would be daily unilateral headache. There probably you're dealing with trigeminal neuralgia. So to conclude on Horner syndrome, generally would have anisocoria which will be worse in a dim light. In a young patient it may follow a severe whiplash injury. In an old patient it can just be not very severe neck injury which can lead to dissection of the layers of the carotid system, which can throw up an embolus causing stroke or MI. So patient with Horner syndrome, ask for pain. If patient is complaining of headache and neck ache, make sure that patient goes to neuroradiologist, tell him that this is what you're suspecting. Ideally they should go get MRI and MRA of neck. One more patient of anisocoria. Patient has ptosis of the right side. I'll let you look at the ocular motility and then please tell me what your thoughts are. Patient is a known case of diabetes. She was initially told that maybe all this is happening because you have uncontrolled diabetes. Patient looking to the right. Looking to that, there is a reason why I'm examining the ocular motility with a torchlight. Looking up. And looking down. Yeah, any thoughts? What was the most impressive problem that you found in ocular motility? Elevation was limited. Anything else? Ptosis, elevation limitation? Yes, we are looking at, probably you're looking at partial third nerve palsy where all the other muscles are still not involved. Anything else? Patient also had larger pupil on the side of this ocular motility. So whenever you have this, again, acquired ptosis, ocular motility problem, maybe it's not a full-blown third nerve as yet. First thing is to say whether pupil is involved or not, whether there is an anisocoria. And again, if you see an anisocoria, see what happens to difference in size of pupil when you switch on and switch off the room light. In this case, anisocoria would be worse in a bright light. This again is a medical emergency. The other sign, and probably this video is not playing since morning, but I'll talk to you about this video. But why we need to look at involvement of pupil in a patient with third nerve palsy. As we would have read in a textbook, surgical cause of third nerve palsy would have involvement of the pupil, medical cause would not have involvement of the pupil. However, more precise statement would be that compressive lesion of the third nerve tend to involve pupil early in the disease process, and one of the commonest compressive lesions of the third nerve is aneurysm of posterior communicating artery, which can rupture any time. So you have a patient with a third nerve palsy which is in evolution but has involvement of pupil. You know that maybe there is an aneurysm sitting there which can rupture any time, and 10% of these patients actually die before they get medical attention, and 50% pass away within first month. So in other words, a potentially fatal condition is going through you. Now so if you have a third nerve palsy, pupil involved, emergency. Even if the pupil is not involved, but if it's a partial third nerve palsy, the previous patient, if the pupil was not involved, it is still an emergency because you don't know whether it is an evolution, whether it's because of compression. So partial third nerve palsy, even without involvement of pupil, is an emergency. That patient should undergo MRI brain in orbit with MRA. There is a lot of literature now to say that any third nerve palsy should undergo neuroimaging, because what you're potentially missing out is fatal, and you don't want to miss out a potentially fatal condition. So now more and more people would advise MRI brain with MRA in all patients with third nerve palsy, with or without headache, or with or without involvement of pupil. Let's look at one more. This is a 38-year-old female. Her predominant problem is that she is not really able to read too well for the last 1 month, and she is not very comfortable going out in the sun. Any comments? I don't know whether it was clearly visible. And isochoria, which pupil is larger? Left pupil is larger. And any comments whether it was more when the room lights are switched off, or whether it was more where room lights are? This is not very, but this was, I can tell you that it was more when the room lights were bright. It was the anisocoria was less in a dim light, but it was more in a bright light. So remember, bright light pupils are supposed to constrict. Parasympathetic system will constrict the pupil. So this is a parasympathetic problem. Now, commonest parasympathetic problem would be third now, but there is no ocular motility issue. So what are you thinking of now? Otherwise, patient is okay. She said that she was told that you have early onset presbyopia. So she came for second opinion saying, should I really be using glasses at 38? By? Very good. So gentleman here is saying that maybe this is AD's pupil and we should rule out by doing pilocarpine test, which is simple test you can do in the OPD. So how do you do pilocarpine test? Instill it in which eye? In the left eye. Left eye is the affected eye. So instill diluted pilocarpine in the left eye and wait. So the only one deviation there is that in these patients you instill diluted pilocarpine in both the eyes. The other eye acts as a control. Diluted pilocarpine is not supposed to constrict a normal pupil. So if the abnormal pupil constricts, you know that there is a denervation supersensitive, which is a pathophysiology of AD's pupil. So these patients sometimes initially in AD's pupil, we used to give pilocarpine as a therapeutic agent, and you see here now the left pupil has constricted after diluted pilocarpine. The other test which can be done in these patients is ask them to read for a little longer period of time. It's also called AD stonic pupil. So if patient reads for around 30 seconds or 45 seconds, you'll find that pupil will slowly constrict instead of an immediate constriction that you will see otherwise. Yeah, that's just the last video. So that's about the pupil and anisocoria. Look for the difference in pupillary size in dim and a bright light. Dim light, more anisocoria, you're looking at Horner syndrome. Bright light, you're looking at third now. But if everything is normal, maybe it's an AD's pupil. But in either ways, third now or Horner syndrome, it's an emergency. Ocular motility, patient can complain of headache, can present with headache. Here is a patient who had an acute onset eye pain, headache, and comes to you with this kind of ocular motility. So there is a ptosis and almost limitation of ocular motility in all directions. So now there are two possibilities. Either patient has a problem either in orbital apex or in cavernous sinus. If this patient had a normal optic nerve function, you're looking at a pathology in cavernous sinus. If he had an optic nerve dysfunction, you're looking at orbital. And in either case, you need to do the neuroimaging, but at least you know that you have alerted the radiologist, as Dr. Quresh said, that either of these region should be affected. Thank you, Dr.
Thank you, Rashmin. Again, that was a lot of take-home messages and a learning for all of us, a small little thing like the pupil and